So it's my distinct honor to introduce our first Rimmel Camp visiting professor, Dr. Gurpreet Dhaliwal. He's professor of medicine at University of California at San Francisco and San Francisco VA Medical Center.
Should I give you these?
Dr. Dhaliwal did his medical school at Northwestern and completed his chief residency, and has been on faculty at UCSF VA Medical Center since then. He's a clinician, teacher, clinical educator par excellence. He's actively involved in evaluation and clinical problem solving, and has written extensively, lectured extensively, and received numerous teaching awards. The title of his lecture is Clinical Reasoning, Good to Great. Welcome, Dr. Dhaliwal.
Thank you very much for that introduction, and thank you everyone for your hospitality today. That was a very nice introduction, but probably the most important thing for you to know about me and where my interest stems in this topic is that I'm a full-time clinician. So I spend all 5 to 7 days a week seeing patients and teaching students and residents as I do it. And I work in 2 settings, which kind of informs my work in clinical reasoning. I spend half my time as an emergency room physician, and I spend half my time as a hospitalist. And I do both of them all year long. So I have this odd job where very often I'm admitting patients to myself, which is a bit of an odd setup. But one of the things it does is it gives me the arc to what goes on into a doctor's mind and a patient's journey when they enter the hospital to the time that they leave. And since the time I left training, what I was really interested in, and I asked my mentors, was not how you get good at reasoning, because I figured if you hang around long enough at anything, you can get good at it, but how do you get great at it? How do you get really, really good at clinical reasoning, which is one of our core things we have to do as physicians, and it's highlighted in the tradition of internal medicine, to label what's wrong with this patient, and then what's the thing we have to do to get them better. And when I asked at the end of my training, I asked the mentors that I really admired, the clinicians I really looked up to, I said, how do you become great at it? How do you become great at this the way that people become great at it in other professions, like music and politics and sports, et cetera? We have books and studies and interviews about how people got there. And they said, we don't know, but you should just read a lot and see a lot of patients. So I got advice, read a lot and see a lot of patients. And I was like, well, that sounds really nice, but I was like, that can't be it. Every doctor reads a lot. That's how we got here. And it can't be just that you got to see a lot of patients, because all doctors see a lot of patients. There has to be something else that from being good at something to really achieving your maximal potential. And that has been my career interest. And in this talk, what I want to do is synthesize some of the insights we can draw in other fields where they really ask that question. Now, every time I mention to someone, my real interest is sort of diagnosis, like labeling what's wrong with the patient that's sitting in front of me. And I want to achieve excellence, both for myself and my trainees who are doing it. Inevitably, I'll start talking about it. They'll start sharing my enthusiasm around it. And then like night follows day, they'll say, oh yeah, I know, you're trying to be like this guy. And I'll say, well, it's true that Sir House MD was a brilliant diagnostician. If you haven't seen the show, this was on Fox. It was featured for about 12 years, and it had this master diagnostician. Between his bedside manner and his absence of teamwork and the incredibly long time it took for him to solve a case, I said, this isn't exactly the type of doctor that we're going for when we're talking about a great clinical reasoner. But sometimes people need a model, they need someone to wrap their head around. And I do tell them that if you want to look to the airways, you can look to a couple of other clinicians who I admired for years and years on end, and they are equally skilled as House MD. So you may know they have a weekly show, or they had a weekly show just like House did. They're generalists, just like House is, so they take all comers that walk through the door, and they get the toughest cases around, just like House does. So by every measure, these clinicians were up to the match. But then they have some things about them that are quite distinct. One of the things is that they solve cases just by history alone, so they're incredibly cost-effective in a high-value care era. They just solve by history and nothing else. The second thing that's tremendous about these clinicians is that they solve 5 to 6 cases per hour. And while House was nice, none of us have an hour per patient anymore. So someone who can move that fast, I think, really melds with our modern sensibilities. And the last thing about these two that I really love as clinicians is that they love their job. And if you can't tell that they love their job, you just have to listen to their show where they're diagnosed because they laugh a lot. But if you don't recognize these two clinicians standing here, you may recognize them in their office because who I'm talking about are two radio hosts. Tom and Ray are Click and Clack. They're the Tappert brothers from National Public Radio's show Car Talk. And in that show, they had taken for 40 years almost any and every car dilemma that could be levied to them inside the continental United States and beyond. Just by maybe applause, can I get a sense of how many people have heard the show Car Talk on NPR or raising hands? Terrific. They are a paradigm of clinical reasoning, and our goal is to say, how could I become like them? How could I be a clinician of their level? And the grounding principle I want to start with before we go through a couple methods is encapsulated in this graph. This graph is the key to developing our skill in anything that we care about in life. It's called the time performance curve, and it describes anything and everything you have ever learned in your life. And it can be things that relate to medicine. So this can be like putting in a central line, running a family meeting, auscultating a heart, whatever skill it is that's central to your work as a clinician follows this. But it also describes anything else you try to do in life, whether it's tying a shoe, raising a child, driving a car. In every single instance, the brain follows this tract, which is when it tries to learn something, the first early stages are very complicated while it's trying to get its head around the subject. Then it gets the hang of it, and it goes on a really rapid learning curve. And eventually you get to a point where things seem pretty comfortable, and you say, hey, I got the hang of it. If you zoom out and try to expand this to a medical career, what this looks like is that the bottom part of the S-curve is when we enter the clerkships. In our third and fourth year medical school where you've left the classroom, you start getting your bearings in the mental model of like, oh, this is what a doctor does when they deal with CHF. Oh, this is what it looks like when a patient doesn't take their outpatient diabetes meds. And you start to get your head around those topics. As you enter residency, fellowship, and for most people, the first 4 or 5 years after their training is done, you're on an incredibly steep learning curve where you don't recognize yourself from the year or two before because the amount that you're uploading into memory and the skill you're building is tremendous. But if you survey most physicians after about 5 years at the end of their terminal training, what you wind up hearing is people say, I'm pretty comfortable with my work. It's not that I know everything, but on any given day when I show up to work, I can handle about 80 or 90% of what walks through the door, and there's a few things here or there that I pick up. And that is a tremendously comforting point. It is a really great point to get to in their career, and I think many people appreciate it. The only issue is that that point of comfort comes with a price, that inflection point, because as the number of challenges per day starts to drop, that means the amount of learning per day starts to drop. And as the amount of learning per day starts to drop, by definition, the rate of performance increase starts to drop. And if we pursue that path day after day, week after week, or month after month, for whatever it is that we're doing, we are on our way to becoming an experienced professional. An experienced professional is fine. We do great service to our patients, to our colleagues, to the students and residents that we work with. But one of the things that we do if we're just striving to be experienced is that we're taking a pass on the opportunity to become expert or achieve excellence. And this isn't a competitive path. It's not something like one doctor gets to do one and the other doctor gets to do the other. This is a bifurcation that any one of us meets when we decide how much better do I want to be at this job. And the purpose of this talk is if you narrow in on one part of being a doctor, because there are many pillars to being a great doctor, but if you narrow in on one part of being a doctor, which is solving the cases and exhibiting excellent judgment and what's wrong with this person and what's the next step to get them better, there's a handful of techniques that other professions have used that we can try to adapt to our world, and that's how I'm going to structure this talk. Now, there's a couple of things that you have to pick up from this graph before we go on. One is it is no mystery why a doctor who's 2 years out of training might not be as good as something as someone who's 10 years out of training. Time and experience definitely matter. But there's an equally important thing that you have to recognize in here, which is just because you do something for a long time doesn't make you good at it. Super important. Just because you do something for a long time doesn't make you good at it. And it doesn't make you great at it either. I can take examples from my life. I have plenty of clinical things that I've been doing for a long time. We were on rounds this morning, and I confessed in front of the whole team that, hey, I've been studying JVP for the last 20 years, and I still find it incredibly tricky. I've been doing it for a long time, but I can step out of that, too, and talk about things in my life. I've been writing ever since I was in grade school, but it's not like Random House Books says, hey, we heard you've been writing for 40 years. We want to give you a contract, or that, I heard you've been driving for 25 30 years, so NASCAR doesn't come knocking on my door and say, you've done something for a long time. I've been a parent for 2 boys. I have 2 boys. They're teenagers and preteens. I love those 2 guys to death, but it's not like either one of those 2 worthless kids nominates me for Parent of the Year. And I feel like I've been doing it long enough, at least I should be in the running. But the thing that those 2 boys know is the same thing that all cognitive scientists do, which is I improve until I'm good enough, and then I divert my mental energy elsewhere. People who are really striving for excellence don't do that. As soon as something becomes easy, they reinvest that liberated mental energy into getting better. And one of the techniques that really points this out is the concept of progressive problem solving. So this is one of the earliest studies in expertise, and they weren't looking at doctors, they were looking at expert teachers. So 2 scholars, Breiter and Scardamellia, said, hey, what's the difference between people who are exceptional teachers and people who wind up being experienced teachers? And what they learned when they studied their profession is that it's no different than ours. When you enter the profession of teaching, there's a series of things that you have to learn. It's like things on your to-do list. So for a teacher, it might be things like devising a lesson plan, disciplining a child, communicating with parents. It's no different than our to-do list, which is like learn about gout, get an approach to visual loss, figure out a differential for jaundice. We all have a to-do list when we enter a profession, and when they watch the teachers as they develop, what they learn is that eventually they get the hang of what they're supposed to do. So you get to a point after a couple of years of teaching where you're like, check, I know how to discipline a child. Check, I know how to communicate with a parent. Check, I know how to create a lesson plan. And they're at that comfortable point where it feels really good. And then what they found was that most teachers do what most humans do, which is they constrain their work and they say, well, I got the hang of this thing. If a challenge comes up in the future, I'll try to figure it out, but for now, I got it. The people who were destined to become the exceptional teachers didn't do that. They got that same joy of checking something off their to-do list, but then in very short order, they put something right back on top of it, even when the challenge wasn't in front of them. So they do something like, hey, I know how to discipline a child. Now I need to learn how to discipline a child with special needs. Or I know how to talk to parents. Now I need to work on how I'm talking to parents who have English as a second language. Or I have a lesson plan. I have my routine. It's terrific. But, you know, I need to get a lesson plan that if a substitute teacher steps into it, it'll be crystal clear to him or her what we need to do. And note the difference between there. All of us learn when a challenge is placed in front of us, but they're pre-preparing their mind for an inevitable challenge that will come their way. And when you see this practice, you will start to see it in different practitioners or trainees you're working with. Like you might see me in a day of clinic and I see someone with a red leg and I say, well, this looks like cellulitis. I might consider if I need to rule out DVT. I'm going to give a familiar antibiotic, and I'm going to send that patient on their way. That's terrific. That's an experienced physician. I thought through things. Everything was great. Someone who's right next to me, and they may be younger than me and even less experienced than me, might be on the road to expertise because instead of doing that, they also see the patient, consider DVT, prescribe an antibiotic, but then they do something else that goes right on the top of their to-do list. So they'll say something like, you know, I didn't cover MRSA, and today noon conference is given by the ID fellow. I'm going to ask her afterwards if she agrees with me not covering MRSA in this circumstance. Or, you know, I'm pretty proud of myself. I consider whether this could be DVT or venous stasis. But if they come back, I feel like I should have 2 or 3 other things on reserve in my differential. I'm going to review that thing now because I want to have that on speed dial. I feel like that's something I should know rather than wait to look it up if that problem comes up later. Or, you know, I'm really interested to know, like, what are the ways that if this, I had a student with me and I was running around in clinic and we literally had 2 minutes before the next patient, what would I have taught that person as we were walking from room A to B? That challenge isn't here today, but it's going to be one day, and I want to prepare my mind. And when Joan Sargent studied high-performing physicians in Nova Scotia, these were the best physicians in a geographic area who were rated by 360 assessment. This is the behavior that she found. She found that those physicians had this 2-track mind. They were worried about the patient in front of them, but they were also obsessively focused on how are they going to get better for the next patient that they see. And make no mistake, these patients, sometimes when people hear these things, they say, oh, those docs must not be busy. It's the opposite. They're the best docs in town, so they tend to be the busiest of all. But they're the ones who still have that 2-track mind. And you have to figure out what your routine is doing, because part of it, if you practice medicine, most of it is the common stuff. And the behavior you'll see is that if you admit someone who's got a really sort of common or pedestrian thing that you might see all the time after you hit that inflection point, like an upper GI bleed or someone who has high platelet counts or someone who has liver disease of uncertain etiology, you can say, listen, that's a familiar case, just like that cellulitis. or you can say there's something on the margin in the most routine of cases that I don't know. And for the MS3 compared to the R1, compared to the chief resident, compared to the 15-year attending, that may be different, but every case has the margin of someone's knowledge. You just have to find out what it is for yourself, and everyone has their style of doing it. My style is that I tend to sort of look things up right on my phone right there and then because it's the easiest time. I have to say in that case, the thing I didn't really know in that GI bleed was why hem-onc was so big on that JAK2 mutation. So that's the thing that I looked up for that upper GI bleed. And the principle behind this habit is called progressive problem solving. It's making a problem for your brain when one doesn't exist. Is that none of us can control what walks in on a call night or comes in through the ED door or who lands in your clinic schedule. None of us are in control of it. So you're never in control of what walks in the door. You're only in control of the learning that you get out of it. So the second method that's really highly endorsed by a lot of fields where people develop cognitive excellence includes the fact that when we make a diagnosis or make a management plan for someone, we're essentially making a guess. It's a prediction. You're like, my best guess is that this is biliary colic. My best guess is that this is a crystalline arthritis rather than a septic one. We make predictions and guesses, and we see how they turn out. Now, it turns out that there are ways to develop excellence in predictive models, the predictive models that your brain does. But before we get to that, I want you to answer a question or think about this. What percentage of Americans think they're an above-average driver? Does anyone know? 93. It's 93. It could be that bad. In fact, it probably is, now that I think about it. But it's not quite that high in the data I know, but it's close. 85, yeah, many of the numbers, it's very interesting. If you do surveys of people in general about their driving, most people believe they're in the statistically impossible 80%, which is everyone's above average kind of range. It is interesting, if you survey doctors on their own self-assessment of their practices, you'll see the same thing. If you say, what percentile are you in terms of hypertension control, A1C control, et cetera, people do that. And I think what people do, because I was human as anyone else, you're probably like, man, I'm pretty good, but I want to seem humble in front of this person who's asking me. So even if my sense is I'm a 95er, I'll just knock myself down to 80, and maybe that'll play well. But when it comes to driving, actually, there's another explanation for it that warrants consideration. So think about the task of driving the way we think about everything else that we do. So every day that I drive to and from work, to and from the store, to and from school, and I have no sentinel events, no ticket, no traffic stop, no near misses, what does the brain do? The brain starts to create a story in its mind that says, hey, I'm a pretty good driver. Like day after day, week after week, month after month, nothing's going wrong. I'm getting to everywhere I need to be. I certainly find myself to be a good driver. And so you start building up this estimation of yourself. Often there's people will create this parallel construct that says, like, yeah, and other people on the road are an idiot. So they're sort of working in both directions as they build this mental model of what happens on the road. And so people live at this 80 to 85% self-assessment because they say, listen, there's nothing going wrong. There's no data from the universe that tells me I should be anything other than a good driver. When you put this in people's car, that changes. So this is called the drive cam, and there's all sorts of other devices that are like that. But fundamentally what it does is it records your driving. It takes snapshots, it takes videos, and it gives you data on how you're driving. And when you put this in your car, what you start to realize is all sorts of interesting data. Like you start to see that the yellow light I thought I was running turned out that it was actually red. I just was seeing yellow, but it was red. When I swerved into two lanes and I swerved between two cars and it seemed like it was very smooth and it went well from my vantage point, when they took the snapshot of the person behind me and I saw the gesture from his hand, which isn't the PG version of it, I recognized maybe I cut it a bit too close. And when I was returning a phone call from the hospital and I took that curve and it seemed like there was no thing, it was pretty easy. It turns out it was. It was very easy for me. There wasn't a problem at all. But it sure was a close call for the little girl on her bike just a meter away that I completely missed because I wasn't there. I didn't see her. And when you put this in, one more super important thing happens, which is people's estimation of their driving drops from that 80% range down to the more statistically valid 50 to 60% range. And they have an innate interest to get better at driving, this thing that they've been doing for their entire life. The world we live in medicine is a little bit like driving. So this is a model of what happens to a physician's mind when they go through a judgment process, usually around diagnosis, but you can extend it to treatment. And there's basically two things that can happen. We can find ourselves being right or wrong. So I work in urgent care in the ER, and I see a lot of patients in a given day. I might see someone who's got cervical lymphadenopathy and a fever, a young man, and I look at him and I say, don't worry, you're going to be just fine. This is a viral URI, and it's going to run its course. And if I find out that it does, you know, I check the EMR, or I talk to his PMD, or I just see him around the VA, which I'm apt to do, and he's doing great, what my brain will do is it'll say the next time it sees that same problem, conduct yourself in the same way. That strategy worked well. If I see him and I find out that, I say, don't you worry about a thing, this is just a viral URI, you're going to be just fine. But then I find out a couple weeks later that was actually his index presentation of non-Hodgkin's lymphoma. And maybe I find out because I was rotating on the inpatient service, or my colleague texts me, or I tagged his record and follow up and I see it. I have the chance, if I want, to get better. I can start to say, you know, that was pretty bulky lymphadenopathy for a URI, or he mentioned that he had lost 5 pounds, but I thought that was nothing. Maybe that signal should have prompted me to examine other vascular beds, or check a or check a CBC or something along those lines. I can do a little better. But for the vast majority of patients, in a busy day in the urgent care, or after a couple weeks on the hospital service where I'm discharging and sending out, there's a huge number of patients that fall in this middle ground where you don't know what happens. And think about it structurally, all the reasons that doctors don't know what happened to their patients. I was covering my colleague on phone call. I sent them to the ER. They left our health system. I rotated off service. The list goes on and on and on. There's a huge number of patients where your brain never gets to know what happened to that story, what happened to that patient. And you have to ask yourself, what do you think the brain does when it doesn't know how the story goes? What do you think the brain does? What do people think the brain does? Yeah, it assumes, as someone said, it assumes it all went well. So the brain operates under a no news is good news paradigm. It fundamentally functions that way. So if I had a busy day in urgent care and I sent that patient out, I'll think that I did an amazing job taking care of him, even if 3 weeks later he's sitting in the hospital getting his first round of chemotherapy. And so what we have to think about is what are the things that we can do in our system to try to improve the feedback that we get. And the feedback is critically important because if you don't get feedback, you know, I've been admitting chest pain for arguably for 20 years, but if I don't create a system where I'm admitting chest pain, finding out who has ischemia, who doesn't, who has a positive stress test and who doesn't, all I'm really doing is building my confidence, but not quite building my competence. And the competence is what the patients are really coming for us. And that's why someone who's done something for a long period of time might continually get more and more confident and get slightly more competent. And someone who's young, who takes this learning mindset, can easily surpass me in a short period of time if they do that. And to do this, it's incredibly effortful. You know, electronic medical records have been part of the problem in a lot of what we do in medicine. But when I follow what young people do to try to incorporate this habit, and I have seen, by the way, the best encapsulation of this habit, not in students, because they don't quite have the volume or the bandwidth to do this yet, and not always in faculty, but consistently in a huge number of residents, that they figure out ways to make this happen. So, you know, over the years, we've evolved from trying to track this on Post-it notes, to index cards, to Excel spreadsheets, to black books, but increasingly they're getting very savvy in creating shadow lists in Epic, or using the computer, as it were, to send themselves a reminder to say, I want to know how this story goes. Or people have setups in their devices where they'll say, I find a way to trigger myself so I know the right thing at the right time. And setting the right time to check a case is critically important. There's some things I need to know, like a microculture, in 48 hours. And there's other things, like a pulmonary nodule, that I need to know about in 3 months. So it's critically important that you have a system that allows you to track quickly, but also triggers you to get the learning at the right time. So as a 2-minute exercise, what I want to have you do is turn to your neighbor and discuss what's your system that you have for tracking patients for learning. And I want to separate this out. Sometimes people say I have a system to track tests, but that's different. That would be like if it's my patient and I organize stuff. But think about all the patients that you may never hear about again. They're not in your practice. You rotated off. You covered for someone else. Do you have a system that allows you to track them so that your brain can learn how the story ended? So just spend 2 minutes with your neighbor, and then we'll carry on. All right, let's come back together. Let's go. So you know how to whistle. Sorry. All right, let's come back together. I want to share, I'm glad that you're talking with your colleagues because this is always a little organic. Like, what is your system? What is my system? What is our system? We work in to figure out a tracking mechanism. But despite the barriers, you'll find a lot of creativity. I'll just share a couple of lessons I have learned. Where did I pick up this habit? I actually didn't pick it up in residency. I picked it up shortly thereafter when I did moonlighting. So I moonlit for 10 years at one of our area hospitals, and I was a nocturnist. So I used to admit, it was very busy. I used to admit 10, 12 patients a night consistently, and it was a tremendous learning experience for me. And I started keeping track of the patients, and what I learned was absolutely humbling to me. Because, you know, I think like most internists, I'm always apt to like track the cool case, like, you know, is this thing mastocytosis or carcinoid or pheochromocytoma? I can't wait to find out, or did that non-caseating granuloma wind up being sarcoid or not? That internist to me always wants to track the interesting case, and I certainly learn from them. But I think the thing that I was most humbled by was the number of times I got the quote-unquote easy cases wrong. Like, oh, I admitted that person and I gave them vancomycin, but that was for their lower extremity venous stasis, which I should have never done. Or I called that person pneumonia, but it was crystal clear by the next morning, if it wasn't the night before, actually, that was CHF. And I think if you're going to embark on this, you have to know it's an incredibly humbling journey. It really, really is. If you really commit to sort of meticulously tracking your guesses, like telling, oh, that patient doesn't need to go to the ER and this one should, and then you learn in short order you gave reverse advice and it should have been the opposite way, you have to be okay with the humility that comes from it. But I have to tell you, of all the things we teach people about learning and CME and lifelong learning, et cetera, this, by far and away, is the best form of continuing medical education you will ever do. And I should say, coming back to the guys on Car Talk, that they do this as well. So people who are fans of the show will know that they have this section called Stump the Chumps. You know, people ask them all sorts of questions, and for every one of them, whether it's mundane, like about their brakes in their car, or a noise that the car makes, or even life advice, whatever it is, they always call people and they say, like, how was our advice? How did we do when we suggested it? And people are very honest. They'll be like, oh yeah, the squealing went away on the brakes when I replaced those calipers. That was terrific. Or, you know, thank you very much. Like, you know, did you get a little more pep in your engine if you replaced that spark plug? They'll say, yes, I did. And even they dole out a lot of life advice if you ever hear them about careers and school and relationships. You know, they'll be like, did you dump that worthless boyfriend like we told you to? Like, whatever it is that they give advice on, they want to know how things ended. And it gets that, you know, when you really listen carefully to them, what you realize, of course, is that they care more about the person than they do about the car. But to refine their mental model, they want to know how they did with both. So the first two methods that I mentioned from other fields are this assiduous tracking of outcomes and feedback, and the concept of progressive problem solving. Oh, I should mention, I didn't give the industry that gets credit. So what's the industry that actually gets credit for the insight that feedback is the most important aspect? It turns out, and there was a clue on the first slide where you saw driving, if you saw storm clouds in the distance, that insight came from research studies on the profession that sits at the very top of predictive ability before the dawn of computers. And it's one you'd never guess because they are the butt of every joke that we ever make, and it was actually the weatherman. So it turns out that if you do studies, academic studies of who are the best at predicting their profession's output, it's the weatherman. And people always blame them because they don't like it when it doesn't come out the way they planned. But if you study them, they're exceptionally good at it. And then researchers started looking at their task and they said, what is it about their job that would make the weather person such a good predictor? And it turns out if the core of their job is simply this, they take a ton of data, they sit, they make a prediction, and then every single day they get feedback on their prediction, and they go back to work the next day and start all over again. So even though you can make as many jokes as you want about the weather person, but it's not evidence-based joking at all, just so you know. So the third method. So those two methods that I mentioned, feedback and progressive problem solving, those are taking the same number of cases I'm seeing, no matter how busy I am, and adding a little bit of extra work. Either I'm going to track how they did, or I'm going to create some reading or some challenge, however brief it is, when none exists. But the other thing that you look in other professions where they really have high-stakes decision makers is that they increase the number of times that the brain faces a challenge. If you want the brain to get good at a challenge, increase the number and variation that it faces. And all sorts of other professions do this. The military puts generals through war games. Businesses put their leaders and students through case studies. And it turns out the best, and of course pilots, as I have here, are put in flight simulators so their brain replicates the challenge before it happens. And it turns out that the academic research on this, or the greatest insight, actually comes from the world of chess. So it turns out in the world of reasoning and judgment, if you're really trying to study the best practitioners, the Drosophila of expertise research, sometimes called, is the chess master. Now, why Drosophila? You may remember from school the poor fruit fly, the Drosophila fruit fly, the probably thousands and millions that got sacrificed so we could all understand genetics, were scrutinized at length to understand that field. The same has been true of chess masters. Chess masters have been studied more than any other profession because they have a very clear task and they have a very accurate ranking system that they use. And when they study the best chess masters, the best of the best, the masters and the grandmasters, what they find is that the chess masters spend an inordinate amount of time reading. They're reading constantly. And it's probably not a news flash that, like the local grandmaster is going to be more likely to be at the library rather than at the bar. Like, that's probably not something I'm telling you. But the key thing isn't that they read, it's what they read, what they spend their time on reading. Because it turns out when they scrutinize the reading habits of the very best chess players, what you would find is they did not read chess research, they did not look for evidence-based chess, they didn't read chess review articles either. When they study what the best in terms of strategy and judgment do is that they read published cases. They read published games. And they don't just read them passively. They go through them step by step, move by move, so that they can recreate the neural trace that's required to pull it up in real time when they have to face it during a match situation. And it's not hard to imagine how we could do that, right? We have tons of cases that come in our inbox, our phone, our mailbox, that allow us to practice. But the key thing is that you can't just read a case passively. You have to replicate what happens to this pilot in a flight simulator, or what that chess master does when they go through a case. Because otherwise what's going to happen is you may look around and say, well, listen, I know the New England Journal of Medicine publishes a case every week, and it usually starts in a really challenging way, and then it ends in a really unusual way. Sometimes it's something I've never heard before. And you say, it's a 25-year-old with a tragic outcome, and then it winds up being schistosomiasis. You would be totally justified to say, that's not going to happen in my practice. I think I'll take a pass. But if you do that, what you're actually doing is you're passing up gold, because the gold in this case isn't the final diagnosis as much as it's made out to be. It's actually all the micro-teaching that happens along the way. So there's a couple of things you have to do if you want to learn how to read a case in simulator mode. You have to not look at the title. It sounds so counterintuitive. Not look at the title, because no one walks into your clinic saying, hi, I'm a 47-year-old man with epistaxis and granulomas. So if that doesn't happen in real life, then you can't read a case that way. Otherwise, you're shortcutting the challenge. It's like the chess game. You do have to block where it comes from and who the specialist is. I have to tell you, if I see an endocrinologist presenting abdominal pain, I get really good at diagnosing adrenal insufficiency. Even though in real life I've missed that diagnosis more times than I care to admit in front of you all. So what you do is you take a path like this. You start to say, let me just start with the case. A 25-year-old comes in with a sudden cardiac arrest, and you stop. And you just do a micro-challenge right there. Like, what do I know? Do I know the reasons a 25-year-old would have this? You don't wait for what they say. You try to conjure it up yourself. It's a concept in learning sciences called retrieval practice. If you read the discussant's thinking first, all of us will convince ourselves, we're like, yeah, I was thinking of that. It's not the same thing as retrieval practice where you force your brain to bring up the list first. And then you go through the case in this way and say, Well, he's in VFib. Do I know what I would have given? If he's hypotensive, can I anticipate that there's organs that are going to be damaged? I see that he's from South America. He's at cardiac arrest. And he's like, aha, that's awesome. I remember Chagas disease. And you may say, what's all I remember is that there is Chagas disease. But even if you got to that point, that's still a small victory. I mean, if you went to Wikipedia and learned 2 more things and then carried on, that's terrific. That's the small upgrade that your brain does. Because the key to these cases is that it's like the flight simulator. It's not about the takeoff or the landing. It's all the curveballs that pilot is going to get along the way. These cases are not valuable because of the rare things that happen at the end. They're valuable because you learn how to exclude tuberculosis this way, and you understand why a great clinician didn't think lymphoma was likely and why they thought that antibiotics should have been given when the white count went to this level. Those are the things that you learn from a case like this. Now, I got to admit, it's still very effortful. I had the habit ever since I was in MS3 of reading the weekly CPC and CPS in the New England Journal of Medicine. It is an inviolable habit for me, and I've never missed a case. But I mean that I've never missed reading a case. I miss a diagnosis all the time, but I've never missed the chance to put my mind through the paces. And the good news is now you can do it in a much easier fashion. I still do it by pen and paper, but that's just by habit. But now you can do it online, and it's actually more brain-friendly and more brain-challenging. So now these cases come in the interactive medical case format, where you get the case, then it asks you a question in the middle of the case. It forces you to retrieve knowledge from your brain, and then you make mistakes and you get things right like I did there, and then it gives you a little teaching, and then the case goes on and on. It's like going to the gym. It's just getting extra exercise, but the way it does it is uploads information. Now, some people say, listen, I'm too busy, I can't even do this every week. And I say, that's fine. Now there's even apps that deliver micro cases where you can learn. One of my favorites that I use is called the Human Diagnosis Project. I get this every morning in my inbox, Monday, or on my phone, Monday through Friday, and they send me a small micro challenge like this. So this is a 25-year-old who had a cough and altered mental status. And then you go through it, and in 4 or 5 minutes, I learn whether I got the case right or wrong. There's some small teaching. There's a little evidence behind it, and I close it, and I'm done for the day. And I have to tell you, it's a little bit like that feedback. Like there's lots of cases where I get it right, and it's reaffirming what I know. This morning, I got the case wrong. This morning's case was someone who had fever, right upper quadrant pain, and totally negative imaging and LFTs, and I didn't know what it was. I thought maybe it was early zoster. I thought maybe it was going to be a right lower lobe pneumonia, but it was just that timeless lesson that sometimes acute cholecystitis in its early phases is totally imaging negative and LFT negative. And I know that lesson, but I forgot it this morning. But by getting it wrong, I won't forget it again. And that's what you really want. The goal of doing cases like this is to have a little bit of the thrill of victory, but you have to endorse the agony of defeat because it's part of doing cases like that. But the way I think this through is that we're really trying to say, like, listen, going to work every day is like a cognitive workout. I'm going to the gym every day. That's the hustle. I'm going to the gym. I'm seeing cases. I'm working out. But I'm doing stuff like this so I can just get in one more rep. And if you get one more rep every day, it slowly builds and yields benefits over time. So try this out. Download this app. I'm a fan of theirs. I have no involvement in it, but find some other things. There's many others where you can get one more case per day. I was once talking at a seminar and sharing this with someone who, she said she does the case of the day on Medscape, and she said, I can't discipline myself, so she does a forcing function. She says, I don't open up my Facebook app until I do my one case on Medscape, and it works marvelously for her. So don't just make a commitment. You have to make some sort of habit. For me, I don't leave the door until I get this one case done. It's 3 minutes of my morning, but it's very well spent. The last method that I want to highlight is this concept that you hear about quite a bit because it's been popularized in both the academic press and in the popular press, which is the concept of deliberate practice. And the principle behind it is really simple, that if there's something we're trying to get better at, like music or sports or something else, there's a benefit to unstructured play, like just keep kicking around the soccer ball or just strumming that guitar. Maybe you'll start to get better. Or you might even follow some routines that your teacher makes. But you'll find at some point to really make a jump, you have to focus on one thing. And anyone else who's had a music teacher or athletic coach knows this. You say, hey, coach, we just want to play some tennis and hit around. We'll get better. We'll be ready for the season. And she says, no, you won't. You're not going to play any scrimmages until you can get 75% of your forehands in the deep court. Then we'll go on. So she knows that's the breaking point. Or you tell your teacher, you say, hey, teacher, I just want to play this music piece. I'm going to get ready for the concert that way if I just keep playing it over and over again. And he says, no. you're going to play this passage that's giving you the most problems, and we're going to get that right, and then we'll plug it back in to the overall package. And people love the idea of deliberate practice. The word even sounds sort of invigorating, and sounds like that's something I can do. But it actually is very difficult to design a program. One of the memories I know of it is someone who did it 40 years ago. So one of my mentors is a master clinician at RVA, and he described the story to me of how he learned about cardiac auscultation nearly a half century ago. So at that time, perhaps not anymore, it was the coin of the realm of an internist, the ability to diagnose murmurs by cardiac auscultation. And he said, you know, he went to a really good med school, but he went as a visiting student to a local sort of hotshot med school, and he said, you know what, I'm going to go there, and now I'm definitely going to learn how to do cardiac auscultation. But he started going on physical exam rounds every morning, and he's like, it was fine. He's like, I saw a rash here. We palpated a joint or a spleen there. We heard a murmur from time to time, but he wasn't getting any better at cardiac auscultation by following around the professor that way. So what he did for the month when he was at that hospital was he went to the pre-op board every night. So at that era, it was the height of rheumatic fever, and so there was a tremendous amount of valvular pathology that was admitted to the hospital pre-op, and patients would sit preoperatively in the hospital for days before surgery. So he would see who was pre-op. He'd go, after the rounds were done for the day, he'd go talk to them briefly, listen to their heart, upload the sound, as it were, the MP4 file of the day into his own memory to recognize what it was that the patient had, and then he'd check the valve pathology 2 days later. He did it for an entire month, and he made a quantum leap in his cardiac auscultation skills, one that he said was unrivaled from the time before or the years after. And to this day, he remains a master of cardiac auscultation. It's not something that any of us can do now. I mean, it's very hard to replicate that sort of thing, but just imagine a modern analogy. Like every time I listen to a murmur, I make a note of what it sounds like and my hunch of whether this is AS or MR, and then I check the echo report that comes a week later inevitably to see which one it is. That kind of thing you can do. And so when it comes to getting better at diagnosis, you just have to think this way. You say, what is the one skill that I need to get better at these coming months? Is it getting better at CSF interpretation? Is it getting better at cardiac auscultation? Is it interpreting a chest x-ray? Whatever it is, commit to that for a couple of months and really do deliberate practice so you make a guess and then you get feedback on the outcome, because you're trying to close the gap between where you are and where you wish to be. And what you'll find is all of us are very fond of saying that we're in the practice of medicine. It's almost a noble term, like I'm in the practice of medicine. But if you're really trying to get better, you shouldn't say I'm in the practice of medicine. You should be very clear on I'm in the deliberate practice of medicine, and pick that one thing that you want to do. That's how you make the real growth play. I want to emphasize something that maybe is obvious if it's not here, which is everything that I'm saying here requires extra work. So if I'm interested in the study of expertise, and there's a whole science behind it, and there has never, I promise you, there has never, ever been a field where people achieve their maximal potential without any extra work. So I'm not trying to conceal that fact. I'm only trying to make the case that it's really, really worth it. You know, people are struggling to sort of find the joy in medicine and the meaning in medicine and combat things like fatigue and burnout, and it's a very complex process. But if you follow a lot of the literature around what gives people satisfaction at work, there's these principles like autonomy, which is difficult for doctors to achieve in this day and age, purpose, which should be front and center no matter what, and then the third pillar, which you'll see in Daniel Pink's book, is mastery. That ability to get better in the craft that you're doing, the thing that you do every day. That is a tremendous driver of satisfaction and joy at work. And I stand here saying that all of us love the point in our times in our career where we're on this rapid part of the curve. And it takes a little bit of extra effort as life gets busier and practice gets busier to stay on it. But the rewards, whether it's you taking care of your patients or you passing on knowledge to the next generation or just an internal satisfaction for yourself, are very, very much worth it. And so in the final, one of our last sessions here, parts of the session, I want you to do this as we review this menu. This is a menu of options for how we can take our practice, which is good, everyone is good, and say, how could I be great in that part of medicine that really matters for me? And this is a menu, and then I'm going to have you turn to your neighbor to see which one might appeal to you. So on-the-job learning, all of us learn when we're on the job. We're all students of medicine, and we learn when the challenge sits before us. But the question is, can you get in the habit of progressive problem solving and find the challenge in advance of it showing up? When it comes to feedback, acknowledge that, yeah, we all get feedback. You know, sometimes a friend texts me, or I have to sign a record, or I stumble into M&M and my patient's being presented. Like, there's feedback in the world. But can you shift from it being sort of a random event to something that's very systematic, where you have your own tracking system that you set up? If you choose among the many, many things that we have to read to start reading cases in this way, can we switch from making it sort of a spectator sport? We're like, oh, that's really cool, that's interesting. I didn't know that, Zika virus does this or that jaundice could have done that, to making it a simulation exercise where you really feel the struggle of the clinicians who are trying to solve that case in real time. And then when it comes to skills, all of us have an infinite number of skills that we're trying to get better at, but rather than having something like hopeless, like I hope I get better at rashes, which I can't say 20 years later I am. Like, can I really, really specific and say for 6 months I'm going to study rashes and take pictures of them and track what happens on biopsy and show it to my friend who's derm or do something else in order to get better at that skill. So just take another 2 minutes with your neighbor, describe which of these things sort of appeals to you, and then we'll wrap up with some final resources to put this into practice. All right, I'm going to call us back to order just so we stay on time. But I hope it's a conversation that you'll continue. Your attention, please. So I just want to make sure we stay on time because I know we're coming close to the hour. I just want to close. I hope you have this conversation after you walk out the door and make a verbal commitment to the person next to you. That you recognize this is not a to-do list. I don't do all these things every day. This is a menu of options. And on some days, with some patients, with some problems, I pick and choose. But I always have the back of these in the back of my mind. And over time, I've picked up habits. The point I want to make is if you'd like to learn more about this, the Society to Improve Diagnosis in Medicine, that's the Quality and Safety Society that I'm very involved with, has a toolkit called the Clinical Reasoning Toolkit. And if you just type that in, you can learn the whole lay of the land of what goes on in clinical reasoning. If you're interested in podcasts, and I love podcasts, that's how I get a lot of my learning and journal exposures, et cetera. One of my favorites is I Am Reasoning. These are by two internists from New Zealand, Art and Nick, and they are hilarious both in their coverage of, they're like the car talks of clinical reasoning guys. So they cover clinical reasoning concepts, go through cases, and really help you understand what's the exoskeleton behind this thing that we do as part of our internal wiring. And then if you really like books and you want to dig deep into it, I'll recommend 3. If you want to understand how the brain is an amazing machine, but also is a flawed one, then you can read Daniel Kahneman's Thinking Fast and Slow. It's a 400-page tome, and it's a bit pessimistic on the brain, but it really is one of the best treatises on how it works and how it misfires. If you want to switch gears and say, what does deliberate practice work look like? Like really, what is the hard work of getting better at something so that I achieve my maximal potential? Then Anders Ericsson's book, Peak, is the book for you. And if you say, I'm really amped on this judgment and reasoning, how do I get better at making these predictions about judgment? Like, what would that hard work look like? Then Phil Tetlock's book, Super Forecasting, which is really how just ordinary people make extraordinary judgments by the humility and training that they put their brain through, is the book that you'll want to read. But the final point about this is remember that this is just a menu of options. Being a physician is challenging, whether you're a student or a resident or practicing in your 3rd, 4th, and 5th decades of a career. It's a rewarding job, but it's a challenging one as well. But the question that I sit before you is everyone in this room is going to be good. I guarantee that every one of us is going to be good. But for that part that really matters about being a doctor, and you have to pick which one it is, are you going to be great? And if you are going to go for greatness, just understand it's not a function of an innate gift. It's not like my practice is different from yours. It is strictly the development of an expert learning strategy. What I tried to emphasize here is that there are discrete things that we know from other fields, but I didn't try to conceal that it's hard work. And sometimes I'm asked by people, they say like, well, listen, why would you do this? You don't get paid extra to do better at this. I don't get a gold ribbon when I get better at diagnosis or I'm more accurate in my judgments. Patients don't always thank me when I do it either. Like, why should I do it? And I say, there's a lot of structural things that stand in the way of this. As we're moving to sort of bundled packages of care and accountable care, it actually does make a lot of sense now to get things right the first time, which some of the old systems did not reward. But I think one of the strongest arguments that ever came was when I was talking about this in the seminar, when I was talking with and a bunch of senior docs were sort of giving me all of those things that they didn't like about it. And there was a younger doctor in the back of the room who said, I hear everyone, but she stood up and she said, listen, if there's any chance I could be a better doctor tomorrow than the one I am today, then I owe it to all of my patients to do that. And the room went silent, and I took a seat myself because I just couldn't have said it better any other way. So I thank you very much for your time and your attention today. It's a great honor for me to be here. Thank you for your interest. I know we're at 1 p.m., so I think if people need to leave, I totally understand, but I'm also happy to take questions. Is that fine? Questions are okay? Okay. Questions are okay. Okay, yeah.
One quick question. Just referring back to that case where you talked about the patient with the lymphadenopathy who could have had malignancy, my question actually is that there are so many patients that we see where not all patients walk in with the diagnosis on their forehead, but there's always that percentage which you're not going to get. And in that case, how do you avoid being defensive and rather ordering too many investigations for all patients? And this usually happens when you get something wrong.
That's right. So, like, let's say I missed something. If I was in urgent care and I called someone's headache a migraine, and then I learned the next day they came back and it was a subarachnoid, you can take it to the bank that I will be like all human beings, and you'll start to see my rate of CT ordering for headaches start to increase. It's inevitable. The question only is whether my brain is wise enough to bring it back down to that previous level, or whether I will reset and for the rest of my career I'll sort of practice in that defensive stance. And the real difference will be how much it's examined. If you're like, oh man, I missed it once, and you start telling that war story to people and you start internalizing it and you pass it around, you will probably be someone who starts CTing headaches at a very low threshold, I guess is the other way to think about it. But if you are mindful and you're like, I really missed that, I've also been tracking many, many other cases that were very similar to this one, and they did not turn out to be subarachnoids. And I've talked to someone else, and I also triangulated the case with them, and they agree it wasn't worthy of a CT scan. You start to learn, where was it that I made a true mistake? There was signal in the environment, and I should have perceived a subarachnoid hemorrhage, and where this was just random variation or the stochastic nature. And however painful that is, I won't change my practice because of that. And it takes a lot of work. Once you start tracking your patients, you start seeing all sorts of mistakes. And sometimes we're not a good judge of what's stochastic random variation versus not. So usually talking to someone else or the literature, you got to get some triangulation from somewhere else is what's needed. But I appreciate you being mindful of that point, because that's a risk of tracking in that way. You can overreact. Yes.
Thank you, Dr. Dhaliwal. It's really fitting that you talk about rheumatic heart disease, because
yes.
Dr. Remmelkamp's most important contribution probably was the demonstration of penicillin in its prevention of rheumatic heart disease with streptococcal infection. And it's in that context of excellence in clinical and research that we have this lectureship, and we are grateful for your participation and your wisdom in that regard.
Thank you very much. Oh, thank you so much.
So why don't we take any other questions? Please come down to the podium.
Yes, I'm happy to take questions here.
That was great.
Terrific. You know when that occurred, I read all about him. But when I was speaking that, I was like, yeah, you're totally right. Like the rheumatic heart disease.
So amazing.
And he did the penicillin work. He did he even did some stuff on the glomerulonephritis aspect of it. So he did all these things about it.
Absolutely. And those are coming on transmission of staff.
I didn't know he did that, because I read some of his work. I mean, his bibliography is incredible. Yeah. Remmelkamp's bibliography, I was reading, like, the stuff he did was incredible. Oh, you want to put this back? That was a very, very deft switch at the last minute. Nicely done. We had to switch mics. I was